my name's Shaffle and I'm a specialist orthodontist based in London, UK. And today I'm going to talk to you about managing complex cases with clear aligners, and we're going to very much talk about theories and principles today and touch on some of the things that Dr. Carroll already talked about. Now tomorrow we'll go through more interproximal reduction, my favorite subject, and I'm going to talk about how I do my contouring. And then we'll talk about treatment of extraction cases with clear aligners. Now, I know in the audience we've got a combination of orthodontists and dentists. Can we put a hands up who's a dentist here? Lovely. And who are the orthodontists? Perfect. So do you guys at the moment do mainly aligners, or do you do fixed braces as well? Mainly aligners? Yeah. Yeah, all the aligners, okay. So we're going to talk about aligners in today and tomorrow, but we're going to talk about pushing them to the limits because, you know, aligners is, compared to other orthodontic research, is a fairly new kind of topic. They only became popular in the late 90s. So the research has really evolved since then, and it's nice to see that in the last 5 years especially we can now push aligners to the limits and start using them for things that traditionally in the past we would have just used fixed braces for. So just a quick disclaimer before we begin. So this presentation is obviously for educational purposes. All of the cases you see in here are my own patients. I'll slow down, thank you, Heather. This is a boring slide, so I'm trying to swiftly go through it. So it's for educational purposes. All of the cases that are in here have been consented to share with you today, and all the images used are licensed. Now, of course, I'm being paid to be here today, and all the opinions expressed are of my own and don't necessarily reflect the views of Dentsply Sirona. So a bit on my background. So for those of you that don't know me, I did my dental training in the UK at Queen Mary's University of London. I then went on to do oral and maxillofacial surgery, worked a little bit in general dental practice, and then I went on to teach in oral surgery. And then I decided dentistry was not for me, and I'm going to move on to orthodontics. So I did my training in the heart of London, right behind the beautiful Tower Bridge. And for those of you who haven't been to London, there is a global symposium happening. I think, Heather, is it September? This year. Definitely very nice time to come to London and visit. But that's where I did my training, so Guy's, King's College and Guy's Hospital. Now I work as a specialist orthodontist in a multidisciplinary dental practice and referral centre just outside of London called the Sanford Clinic, and it's just recently been renovated, so we're very much enjoying working there. Now, I'm very lucky because I work as part of a very big team of 22 dentists and specialists. And I actually work with my father, who's the implant surgeon, my husband, who's a dentist, and also a couple of other family members. But these guys keep me very busy, so I do all of the orthodontics at the practice, and the majority of my cases involve aligners, fixed appliances, and using TADs. So that's enough about me. Now today we're going to talk about the overview of the factors affecting predictability of tooth movement during clear aligner therapy, favourable and unfavourable tooth movements, which Dr. Carroll touched on earlier. Benefits of an adaptive trim line design. I'm very passionate about trim line design. And last year and the year prior, I did a collaborative project with Dr. Bankhead, where we really delved into the research surrounding trim lines. So we're going to talk a lot about that. Overview of attachments and the effect of trim line design on aligner mechanics, and then applying theory into practice. So I wanted to briefly share with you my journey with clear aligners. Now, it's been very much a love-hate relationship. I can't say to you that I was confident with aligners. In fact, I can confidently say I used to hate them. Now, I used to use a brand that a lot of us know, and I just wasn't happy providing my patients with it. And what would happen is a patient would come in for a consultation, and I would convince them into having fixed braces. And of course, the ones that I couldn't convince would end up going somewhere else and having clear aligners done elsewhere, which is not really ideal to be losing patients. So I started a journey to find a system that I was going to be confident in providing my patients, and that's when I came across SureSmile. And I guess for me, what I loved about this system was that it wasn't a clear aligner brand. they had a history of knowledge in orthodontic biomechanics and a history of fixed appliances, as Dr. Carroll said earlier. So it was a system where you could, as an orthodontist, use to plan whether it's your fixed appliance cases or your aligner cases. And I always remember my father, who's a dentist, he always used to say to me, look, Nina, if you don't have confidence in a product you're offering to the patient, how do you expect the patient to go ahead with it? And it was so true. So learning to use aligners for me was a little bit like learning how to swim. You want to take small baby steps before you jump into the deep end. So I want to share with you my first few cases that I did with SureSmile. And I always believe we learn the most from our first 10 cases. Now, this was my very first one. It was a class 3 edge-to-edge incisor relationship with mild crowding and a mild centerline discrepancy. And this is after 14 months of active treatment. So the case went well, the patient was compliant, so I thought, well, so far so good, let's try another one. Then we tried a class 1 malocclusion with increased overbite, moderate crowding, and a mild centerline discrepancy. And this is her after 13 months of SureSmile aligners. And we also did a little bit of edge bonding. In fact, the dentist did, my husband. And again, the case went pretty well. So then I thought, well, let's try something a little bit more challenging. Let's do a class 2 division 2 case with a deep bite and an increased lower curve of spay. And this was after 14 months of active treatment with clear aligners, SureSmile. So what did all of these cases have in common? Well, it was the high level of predictability that I hadn't experienced with the previous aligner brand that I was using. But it's important to look at what led to this increase in predictability and why was SureSmile so different to the other brands. Well, let's talk about the factors that affect the predictability in aligner therapy. So there are multiple studies in the literature that show that the outcome is affected by trim line design, so the material and the thickness, attachments, interproximal reduction, and the type of movement, but also patient factors. So patient factors are, of course, compliance, but also, do they have recession? Are there, undercuts in the teeth? What's the tooth anatomy like? The root to height ratio? So how can we change the properties of the aligner to increase the predictability of the tooth movements? Now, I mentioned earlier I'm very passionate about an adaptive trim line, but let's look at why it's so important when it comes to aligner therapy. Let's take a closer look at the research on the trim line to understand better the importance of it. Now, this was a very nice study published in 2023 from a group from the University of Bonn in Switzerland. And they looked at the effect of changing 3 design aspects of the aligner and the force transmission of a tooth. So you can see there they looked at trim height, the trim type, and the thickness. Now, what did they find? Well, higher forces were seen going from scallop to a straight trim line, moving on to a higher trim height, but also the thicker the material. Now, of course, you're not necessarily in control of the material that you use unless you're doing DIY aligners at your own practice, but it's important to consider that when we're planning our treatments. Now, the same team also published a study in 2022, and Dr. Carroll showed this earlier, but I'm a very visual person, and I personally absolutely love this study. And what you can see here is it shows the force transmission on a tooth with scalloped and scalloped extended, but also straight trim line and straight extended. But what I want to highlight with this study is that if you look at scalloped, the forces that are seen on the crown of the tooth are only in the incisal 1/3. Now, what does that mean for us when we're doing tooth movement? Well, your center of resistance of the tooth is within the root. The force that's being applied is very far away from it. So how are we possibly going to carry out complex bodily movement? And if you notice at the gingival margin there, there's absolutely no force. But if you look at extended or straight trim lines, excuse me, let me grab a sip of water, you'll notice that the forces are distributed more evenly across the tooth surface. And especially with the straight extended trim line, look at the force at the gingival margin. So, of course, to carry out more complex bodily movements, this is going to be a lot easier. Now, this was a study by Cowley and co-workers in 2012 that helped SureSmile develop its strategies. And again, Dr. Cowell showed us earlier. And they measured the force required to remove the aligners for 3 trim line designs and different materials. And what's interesting is when they went from 0 scallop to 0 straight millimeters, the force more than doubled. And when you go onto 2 millimeters straight extended, the force goes up by 4 times. And it didn't matter what material was used, the same pattern was seen across all materials. So this is an important study to show us how trim height can really affect the properties of your aligners and the biomechanics. So how high do we go when we're designing our trim height? Is there a limit? You know, how do you keep going and going? Well, this study by Gao and Wieshelhaus in 2017 looked at 3 different heights, so 0 to 1 millimeter, scalloped, 3 to 4 millimeter extended, and then a super extended. And what they found was a significant difference in the stiffness going from scallop to extended, but there was no statistical difference going from extended to super extended. So that tells us that there is a threshold. Once we reach that threshold, there is no advantage to going higher and higher. Now, this was a very nice systematic review published in December last year. And what they concluded was that trim line design influences the efficacy of orthodontic tooth movement. And it essentially summarizes 2 main things. And the force and moment delivery is much better for straight trim lines compared to scalloped. And that means movements such as intrusion, translation, tipping, root talking is going to be carried out a lot more effectively. And if we look at aligner retention, again, aligner retention was better with a straight trim line as opposed to a scalloped. Now, trim height is such an important factor, but how do we actually apply it to our daily, clinical use? Now that we've learned a little bit about the research, let's apply it into clinical practice. So this is a table that I created, and it's also published in Dr. Carroll and Dr. Ahad's white paper. But essentially, a scallop trim line, as mentioned earlier in the visual study, it's a weaker system. You're not getting forces at the gingival cervical margin of the teeth. Now, weaker system means it's also going to be a little bit more flexible. You may want that, but sometimes you may not. Now, you will have to rely on using more attachments because of it being a weaker force distribution on the crown of the tooth. You are going to have to compensate. And sometimes you'll need to rely on overcorrection. So when would we actually use a scallop trim line? Well, if you have very severe crowding, because there will be such big discrepancies in the movements that if you're using a straight trim line for the get-go, you're not going to be able to really engage into those teeth. If you're doing isolated extrusions, again, because you want something that's a little bit more flexible, if you're doing rotations, if you have recession and large undercuts, and also if it's a very complex case where you're using multiple attachments. Now, what about a straight trim line? Again, going back to that visual study I showed you, you get better and more even and higher force distribution on the tooth. But the aligner becomes less flexible. So if you're using it from the get-go for a very crowded or rotated case, you've got to be careful. Also, manual dexterity, if you've got slightly older patients, they're not going to be able to remove it. But also, you will have fewer attachments and less need for overcorrection. So when is a 0 millimeter straight trim used? Well, it's good for most cases. I like to call this the universal trim height because it's a nice balance between flexibility and stiffness. Now, then you have, you can go up to 0.1, 0.2, all the way up to 2 millimeters. And there's a number of factors that affect why and your choices and why you would use one over the other. But a 2 millimeter straight trim is great for bodily movements. Again, if we think back to the visual study I showed you earlier, 2 millimeter trim height gives you the best distribution of forces on the tooth. So if you're doing expansion, you're doing leveling curves of Spey, torque control, this is essential. And if you're on the Ortho platform, this is what it would look like when you're ordering your aligners. So for almost everything, I can't actually think of a single case where I don't use the adaptive feature. And I will always start, not always, but most of the time I will start with a scallop trimline just to get the patient used to it. I treat a lot of older patients. The average age group that I treat is about 50 to 60, sometimes as old as 90. Generally, I try and stay away from 90-year-olds, but generally speaking, you need to assess the patient's manual dexterity, their lifestyle, how much crowding, how much rotations. But you can start them off with a scallop trim line to just get them used to it. Then we move on to a straight trim, and depending on what movement you're trying to do, what correction, so if you're correcting overbite, if you're doing torque, if you're expanding, then really you want to go as high as possible. But why can't we always go in with 2 millimeters? Well, it depends on your attachments. If you've got lots of attachments, how is the patient going to remove it? And also, really, you shouldn't be using that high of a trim line. Yeah, of course.
I have a question.
Yeah.
Are you changing your attachments between scallop and straight?
No, so basically, no, that's a very good question. So, no, I know with Dr. Bankhead, he sort of fits his attachments at sort of stage 3. I do all of my IPR, not all of it, but I start my IPR at stage 1 and I place all of the attachments at stage 1. For me, the way I do my consultations, I really set the expectation from the patient. I say to them, look, you're going to spend all of this money, all of this time, and potentially, if you're not 100% compliant, it's going to be a total waste because it won't work. So I really, really try and be very selective in my patients. So to answer your questions, yes, attachments go on from the very start. Whether I use scalloped or straight trim line, that doesn't affect the attachments. However, if I know for that case, for example, I have a lady who's suffering from periodontal disease, very long crown heights, lots of gingival recession, I know that I'm not going to be able to put her onto a high extended trim line. So for that case, I knew I'm going to be using scallop throughout most of the treatment. But then I know that because I'm using a weaker system, more flexible system, I'm going to have to overcompensate by adding more attachments than I would normally. So I hope that answers your question. So, now we've talked about the theory and how to apply it clinically. Let's look at what we've learned and apply it to this case. So this patient presents with mild crowding with 45-degree rotations of the lower right 4 and lower left 5. Now, how would you design this trim line? Well, although a straight trim line is generally ideal because you get better force distribution, why didn't I choose a straight trim line from the very get-go? Well, look at the rotations. If you're using a straight trim line from the get-go, you're not really going to be able to engage into those rotations. Very similar to if you were treating a fixed appliance case, you wouldn't go in with a 1925 stainless steel. You start with a 014 or 016 night high to derotate, then you'd move up. It's exactly the same principle. The other option is what Dr. Carroll said. You slow down your degree of movement. So instead of doing 2 or 3 degrees, you would slow it down to 1 degree. Now, another thing that I love doing as well is if, for example, I get a case back from the laboratory and the upper aligners, it says, let's say 20, and the lower it says 10, I will ask them to slow down the movement as much as possible to get equal upper and lower active aligners. The other option is couple mechanism. If you've got very severe rotations and you know you're going to struggle for the next year or 2 years, just go in and do a couple mechanism. Now, we've talked a lot about trim lines, and which is a very powerful feature of SureSmile, but how is this actually interlinked with attachments? So first, let's go back in time and look a little bit about the history of attachments. So as I mentioned earlier, aligners became popular in the late 90s. And the first generation of aligners didn't actually have any attachments, but they soon realized that some of the more complex movements were not tracking properly. So in the second generation, in the early 2000s, they introduced attachments as a means to overcome these weaknesses. So most of the research we have available to us is based on a scalloped-only aligner brand. Now, as I showed you earlier, when you're using a straight trim line, the biomechanics and the forces are totally different. So when we're applying scalloped-only principles to straight trim lines, we've got to be a little bit careful. So what are the factors that influence the need for attachments? Well, trim line design, type of movements, staging movements, your tooth anatomy, and of course mobility. And within the software, we have certain thresholds. Once you reach that threshold, an attachment is automatically added. But why are automated thresholds not enough? Why do we need to sort of know a bit more about when and why we use attachments? Now first, let's go back to basics. We all know this, but to understand the fundamental difference between how fixed braces work and aligners work. With fixed braces, we're pulling teeth, and with aligners, we're pushing teeth into a reservoir. And certain movements are more difficult with aligners, and they require an attachment to act as a pushing surface to push the tooth into place. And the larger your pushing surface, the more surface area, the better the movement is going to work. So when do we need attachments? Well, as I mentioned, certain movements are more difficult, so mesial distal tipping. If you're extruding teeth, in particular individual isolated extrusions. Space closure, if you have large rotations, and significant intrusion or leveling curves of spay. So what do we really know about how well teeth move with aligners? Well, this was a prospective study by Huili et al. In 2020, and they compared the predicted versus final outcomes of treated patients by superimposing the models. And what they found was that the average accuracy was 50%, so that's not really a lot. That was actually a marked improvement from the previous study by Kravitz in 2009, and that was an improvement by 9%. Now, the highest accuracy was your buccolingual crown tip, 56%. Lowest accuracy was rotations at 46%. And incisor intrusion remained a challenge, but maxillary incisor extrusion improved. Now, let's look at this case. So, now I want to compare, the top row is a case I submitted to SureSmile. And I'm going to show you in a second, the bottom row is the same parameters, the same movements that I submitted to another aligner company. And what I want to show you is look at the number of attachments we have with SureSmile. So there's about 7 attachments on there. Now to keep the next company anonymous, I've marked the attachments in red there. Now, believe it or not, I used to do art. I know it doesn't show. Now, notice we also have blue markings on the incisors. So those are power ridges. Why do we have to have power ridges in this aligner system and not in the other? Well, it goes back to what I said about the straight trim line. With a straight trim line, we are getting forces at the cervical margin. You don't need a power ridge. With the below case is a scalloped only aligner brand, by the way. But you need ridges there, power ridges, to add torque at the cervical margin, because with a scalloped only brand you are not getting any torque at all, any forces at the cervical margin. So this was a retrospective study published in 2023, and they compared the outcomes of setups submitted to 4 different companies. And what they found was that the number of aligners were very similar between all of the companies. But despite all of the teeth being moved similar amounts, the setups were all coming back very different. But what was interesting about this was that the number of attachments in SureSmile was almost half of the other companies. So why is that? Again, it goes back, there's many different factors, but the main reason is the adaptive trim line. You're completely changing the forces and the biomechanics. So you don't need to rely on, on attachments as much as you would normally do. So how do you choose your attachments in terms of shape, size, position? And when you get your setup back from the lab, do you just accept it? Do you amend it? Now, I'll be very honest with you, this used to be a very confusing topic for me, because I'd get it back and I'm like, well, what do I do now? Do I touch the attachment? Do I not? Do I rely on the lab? They probably know more than me, so let's leave it alone. So this is what's available to us now on the SureSmile platform. So, but which one do you use and when? Now, the top row, we can see the rectangular attachments. In the second row, you've got your beveled attachments. And then you've got your ellipsoidal ones, which I don't know if any of you use. I personally don't, because a lot of the studies do show that they have very little benefit. And the main reason for using it would be for anchorage reasons. But if you want something to provide you anchorage, go for it with a bigger, larger attachment. And this is what Dr. Carroll was talking about. So, and Heather, do you actually, you know, you can change the settings on your platform. And this is what mine looks like. And the software will add automated attachments on there, but you can go in and change that according to your preference. Now, the research tells us that when you're doing rotations of more than 15 degrees, it's extremely unpredictable. But notice here, now I haven't got a clicker, but if you go down to rotations, you'll notice that mine says 6 degrees. So that means that's the threshold when my cases are going to have an attachment place for a rotation. And anything above 5 degrees, I would add a rotation, because I know from experience and research, it's not going to work very well. So let's look at the research. Now, the majority of the evidence, as I said, excuse me, is based on straight trim lines, scallop trim lines when it comes to attachments. But what evidence do we have out there that compares when using straight trim lines with attachments? We don't have a whole lot, and the majority of the studies are actually from 2021 onwards. Now, this was a study published in December by the same group that I showed you earlier with our visual representation diagram. And I think this group is fantastic, and they're really leading a lot of the research on straight trim lines. And as you can see here, they compared scalloped versus straight extended trim lines in combination with no attachment, horizontal attachments, and vertical attachments. And they investigated 3 different movements, so your facial translation, distalization, and extrusion. So what did they find? Well, when it came to facial translation, you can see from the bar chart there that an attachment has very little impact on the force. However, straight extended trim lines produces significantly higher forces compared to a scalloped. What about distalization? So when you use an attachment, it increases the force intensity in the distal direction. Now, if you look at the horizontal attachment, you'll notice that there is a slightly higher force produced there. But again, forces produced by a straight trim line is much higher than a scallop trim line. Now, what about extrusion? So rectangular attachments are essential in achieving the necessary force levels. If you look at scalloped, you'll notice scalloped with no attachment just doesn't produce enough force. So how are you really going to carry out any extrusive movements? But even if you add an attachment, look at the force levels, they're very, very low. Now, you might look at that and think back to your dental school days and say, well, actually, that's more or less within the region of forces that we need for orthodontic tooth movement, but it's not. Because although Profit said that between 0.5 to 1.5 newtons of force is what we need for orthodontic tooth movement, that's not the case with aligners. Because within the first couple of days, you get a real depreciation of the force to leave only about 10% of what you originally, when you originally fitted it. So, you know, depreciation from 100 to 10% is a lot. So actually, you do want to apply about 6 newtons of force to then compensate for that force depreciation that's going to naturally happen. So with the extrusion, rectangular attachments are essential, and when no attachment is used, there is insufficient force for extrusion, whether you're using scalloped or extended trim line. And what they also concluded was that straight trim line enhances control and can sometimes replace the need for attachments. So when do we use what attachment? So I created this little diagram for you to be able to just visualize it, but also summarize it. So vertical rectangular attachments can be used for retention, distalization, as you saw from the previous study, angulation control, root control, so during space closure especially. Horizontal rectangular, again, can be used for retention, distalization, and to the going back to the previous slide I showed you, there's a slightly higher force when you're using a horizontal rectangular for your distalization cases. Root control, again, space closure. Vertical beveled rectangular attachments, so again, retention, rotation, and you can see the red arrow, that's the direction of the force, and then the blue arrow is the moment that's going to happen. So horizontal beveled rectangular, again, great for retention, and in fact the beveled ones are slightly better for retention. But you can combine this with the movement that you're trying to do. So if you're extruding teeth, you'd be using a gingivally beveled attachment. If you're intruding teeth, on the bottom row there, you can see it's a occlusally beveled attachment. Now, like Dr. Carroll said, if you have a particularly stubborn tooth, like for example a lateral that has a bit of a rotation and an angulation issue, and you want to extrude it, I'm sure we've all had that where you do refinement after refinement, it's still not coming down. So you can use a sash design, and that basically combines the forces. So you place the attachment at 45 degrees to allow you to do an extrusive force, but also correct the rotation or the angulation. So, what about attachment positioning and orientation? So where do you position your attachment? Well, it's a balance between the center of resistance, the magnitude, and the direction of the applied force. And if the planned movement requires a tooth to move along multiple axes, you need to consider that. And the direction of these movements need to be taken into consideration when you're planning your attachment design. And when it comes to gingival margin, one thing we need to be aware of is that the aligner material is the thinnest at the gingival margin. So if you're placing your attachment very close to the gingival margin, you are going to potentially warp that aligner material. It's not really going to do a whole lot. So you do need to bear in mind how close to that gingival margin you are. But on the other hand, you also want your attachment to be closer to the center of resistance of the tooth. So really, again, closer center of resistance means more gingivally. So there are multiple things you need to consider when you're positioning your attachment. And the other thing as well is occlusal, occluding on the attachment. On the platform, if you are occluding on that attachment, it will highlight it to you. So there's multiple things you need to consider. So what about the materials for attachments? So who uses flowable in this room for your attachments, and who uses the posterior packable composites? Can I have a hands up for flowable? So one flowable, not a lot, so two. So the rest of you use packable, fine, yeah. So,
and you?
I'm going to tell you. Now, I actually used packable before I knew about the research, but and I'm going to tell you why in a second. But really, the research tells us we need to use composite with a higher filler content, so up to 72%. More than 72%, it doesn't really make much of a difference. And what the studies show is that when you're using up to 72% of filler content, you increase your accuracy and bonding strength. And the other thing to consider is better shear bond strength, but also transfer accuracy. Now, and also wear resistance. When I used to use a flowable composite, and this is why I no longer do that, but again, it depends what material you use, because some flowable composites have a very higher filler content. But the issue that I had was the patients would come back, and when I would take the pictures for my refinements, I would see that the attachments have lost their sharpness. So when you lose that, bearing in mind you're relying on the interaction with your attachment and your plastic to produce the accurate movement. If you're wearing down your attachment, you're not going to get the same accuracy of movement. So it's important that from start to finish, your composites are very defined, very sharp, and actually large attachments perform much better. So for that reason, I use posterior packable composites with more filler. And when I say my orthodontic therapist, I actually stopped packing them myself. It's very nice when you have someone to help you. So let's look at this case of a 20-year-old female who presented with a Class 2 Division 1 malocclusion. Now, I'm hoping this Menti questionnaire will work. Could I get everyone to get out their phones and just scan the QR code? We're going to make it a little bit more interactive, and it gives me a chance to rest my voice. Now, that should take you onto a Menti questionnaire. So just to summarize, so this patient had an overjet of 5 millimeters, an increased overbite, and you can see that lower center line is shifted to the left by 2 millimeters. We've got a little bit of mild crowding. We've got some rotations on the lower right 4 and lower left 5. And the molar relationship on the left and right is 3/4 class 2. Now, just to give you a bit of background, we also have unerupted all 4 wisdom teeth. So what is the most difficult part of this malocclusion to correct? Now, it doesn't show on my screen, so I'm going to have to go on here. So if everyone can cast their votes, I'm going to step to the back of the room. So the highest vote is for rotations. Molar relationship is close second. We've then got overjet, center lines, and the vote for overbite is very low. So most people, oh, just keeps changing. This is exciting, it's like a race. Who wins? So rotations looks like it's in the lead. So has everyone voted? We've got, I can't see the number, but everyone's voted? Yep, perfect. So rotations wins. So let's look at the occlusal views of this simulation and the planned attachments, and you can see some yellow markings there on the upper occlusal for the class 2 elastics. But you can really see the severity of the rotations on this. Now, look at the movements table and let's inspect the attachment design. And this is not an attachment design that I modified myself, it's what I got back from the lab. So it really highlights that we need to have some knowledge to review the attachments and modify them to improve our biomechanics. And in particular, if you look at the degree of intrusion, you can, of the lower anterior segment, you can see it's quite significant. And look at the lower left 5 movement highlighted in red. We're trying to carry out 57 degree of derotation, and the lower right 4, 47 degrees, so that's quite a lot. And as I mentioned earlier, the studies tell us that anything more than 15 degrees of rotation with aligners is a challenge to correct. Now, if we look at the premolar attachments, what do you think of them? Do they look okay to you? Would you do anything differently? Yeah, they're quite small, aren't they? Now, so let's look at the clinical photo, and which will give us a bit of an insight as to what's gone well and what hasn't. Now, you can see the buccal segment relationship has significantly improved. So we've gone from 3/4 class 2 to class 1 on that side. The canine relationship is class 1. The overbite has improved. It's not great. Still needs some correction. But a lot of the correction is more the lower incisors need to procline forward to open up the bite. The midline is nearly corrected. Again, not 100%. Our left buccal segment has improved, but look at the lower left 5. Now, I know the attachment's missing on this picture, but that's because I identified it was too small. So I took it off so that when I did my scan for refinement, I was going to design a new one. Now, you can just leave it on and then take it off after you do your, once you've got your refinement plan back, but I chose to take it off there. And, you know, it is very small, I agree. So let's review the original attachment design, and there should be another Menti. Now, let me see if I can start. So we touched on this, but how would you design, you know, things differently to improve the derotation? So would it be a larger attachment? So if everyone starts voting, there's a few different options there. Would some of you give up and just put fixed appliances on? Yes, of course. Let me go back. There we go. This is the first time I'm using Menti, so I'm quite impressed it's working to some extent. Oh, sorry. So back to this, how would you design things differently? I'm going to step forwards because I can't see on my laptop. Very good. So most people are voting for large attachments. Some people are voting for IPR, and we're going to talk about that a little bit. Buttons and elastics, fixed appliance, one vote. Yeah, so the majority are larger attachments. Okay. Now let's look at the systematic review, which talks about the factors that influence your derotation efficacy. And rotations, as I mentioned earlier, are particularly difficult movements to do with aligners, even with fixed appliances. And so it's important to understand that when we have conical teeth, they can be more difficult to derotate compared to, let's say, a molar. So it's important to use an attachment to increase the effectiveness of the derotation. Now, I don't know if anyone who's kind of used a scalloped aligner brand has ever explored using 2 attachments when you're doing derotations. Does anyone do that? No? So there is some suggestion to use 2 attachments, but the research tells us that 2 attachments to try and get a couple rotation doesn't work. It's less effective. So 1 attachment is enough. But larger attachments with sharper edges perform better. The amount of movement, so success drops when you go above 15 degrees of derotation. So again, my personal preference is to add an attachment if I'm doing a derotation more than 5 degrees. And as I showed you earlier, go into your preferences. You know, if you haven't already done it, go in today and change your preferences so that attachment is automatically added in. IPR. So a lot of studies show that when you create space prior to derotating, it improves the success of the derotation. So, you know, either do the IPR or expand, create the space, and then do your derotation movement. Staging, so reduce the speed as slow as you can. So 1 degree of rotation per aligner. Sometimes, as I mentioned earlier, if I have double the number of attachments, aligners in the upper arch, and I've only got, let's say, 10 aligners in the lower arch, I will sometimes ask the lab to slow it down. And if they can't slow it down enough to get equal upper and lower active aligners, I sometimes say add in 1 passive, then 1 active, 1 passive, 1 active. That way you can slow it down again. Using buttons and elastics and patient compliance. So we've talked about all the things we can do to improve derotation, but none of it matters if your patient is not compliant. So choose your patient from the start. So let's dissect, bless you, this Class 2 Division 2 case and talk about overbites. So we've got mild crowding in this case. We've got proclined upper lateral incisors and an increased overbite. You can also see that the lower incisors are slightly over-erupted with an increased curve of spay. So what are the main aims of our treatment? So aligning the teeth, leveling the curve of spay, and reducing the overbite by intruding but also slightly proclining the teeth. Now, what about the upper lateral incisors? So we need an element of retroclining and extruding those. Now, as Dr. Carroll said, if you're retroclining and extruding, that's a synergistic movement. They work very well together. So actually, if you combine that movement together, it will make the effectiveness, it will make the outcome of that movement much better. Now, let's briefly talk about the biomechanics. So as the lower anteriors are being intruded, the aligner material will try and lift off. So using an attachment on the premolars is essential. These are your anchorage attachments. Now, if you're also doing a bit of a derotation, extrusion, intrusion, you can orientate that attachment to also accommodate that movement. So you can see in this case, the lower left 5, we're derotating it distobuccally. So we have an attachment for anchorage, but also it's beveled to derotate that tooth. Same with the lower left 3. Now the lower right 4, again, we're derotating those teeth. Now what trim line did I use for this case? So going back to the study I showed you earlier, we want a straight trim line to carry out our intrusion. A scallop trim line is just not going to be effective enough. But how high did I go? Well, I chose 0 millimeter. As I mentioned earlier, 0 millimeter is a nice balance between flexibility and stiffness. Now, the reason I chose 0 millimeters is because of the attachments that I was using, but also the level of curve of spay. The patient was also not very dexterous, so she didn't have nails. She really struggled taking things in and out, so chose 0 millimeter. But really, the moral of the story is the higher you go, the better your intrusive forces are going to be. But your choice of how high you go depends on your patient, all the factors we've talked about. So notice no attachments are on the upper lateral incisors. And if you were doing this case with a scalloped only aligner brand, you probably see lots of attachments on every single tooth. But with SureSmile, you don't need that. Now, the upper laterals don't have an attachment because it's not necessary. We're carrying out a synergistic combination of movement of extrusion and retroclining the teeth. But why did I have attachments at all in the upper arch? Well, I needed them because I had class 2 elastics. If you're using class 2 elastics from your canines, you need an anchorage attachment. Otherwise, the plastic will just peel off the teeth. It's not really going to be doing what it's supposed to do. Now, the orientation depends on what other movement you're doing. So on the upper left 3, you'll notice there's a occlusally beveled attachment. There was a couple of degrees of intrusion that I was doing. So I think it was something like 0.3. So bevel it towards the movement that you're doing. And on the other side, we're derotating that canine so the bevel is orientated to allow the derotation to happen. So this is what 14 months of SureSmile treatment looks like with a straight trim line. And as you can see, we've really intruded the lower incisors very nicely and flattened that lower curve of spay. Now, for all of my cases, I also do a little bit of just artistic contouring of the edges. I just use a Soflex disc, and not to fix discrepancies or things that I couldn't correct, but rather to take out any uneven, jaggedy edges. So how well do aligners actually control overbite? So this retrospective study specifically looked at overbite control. And what they found was that overbite control is very much linked to your incisor position. So if you procline the lower incisors, you're going to open the bite. If you retrocline them, you're going to deepen the bite. They also reported that on average 1.5 millimeters of bite opening or deepening was achieved. And that's actually only half of the amount typically we see with fixed appliances. So it makes life very difficult for us if we're using a scalloped only aligner brand to successfully correct our deep bite cases. So this study really shows that using a scalloped only aligner brand doesn't really satisfy the treatment demands when correcting overbites. But that study was from 2017, but surely by now things have improved. Well, let's look at a more recent study from 2023 looking at overbite correction with a scalloped only aligner brand. Again, the mean overbite correction is only 33%. They saw 1.15 millimeters of improvement after the first set of aligners, and overcorrection and refinement was needed for all of the cases. Now, what about using bite ramps? So there should be another mentee here. So does everyone know what a bite ramp is? Yeah. And do you guys use them for your deep bite cases? Do you use bite ramps at all? Now, if everyone casts in their vote. So do bite ramps improve the predictability of opening the bite? Now, whilst you're all voting, this screenshot here was a very nice study, very well designed study from 2022, which compared the use of smart track material with and without using bite ramps. Now, they also compared it to another material, which was also really nice to see. And what they found was that bite ramps does not improve the efficacy of your bite opening. Now that's interesting because we've been taught that use bite ramps, even in fixed appliances, we use, GIC or composite to open up the bite. But when it comes to clear aligners, bite ramps don't actually improve things when we're correcting the overbite. What about leveling a curve of spay? Well, this study from 2022 demonstrated that the mean accuracy was 35% with a scalloped aligner design. And they even recommend auxiliary appliances to improve the leveling. Let's look at that case and how we can use SureSmile and all the benefits we talked about in terms of trim line. And this was a 61-year-old gentleman. His case is not finished, but I want to show you his mid-treatment progress compared to the simulation. Now this is a simulation of where he should be at, and this is where he is now. And it's almost identical to what we have on our simulation. And how have we achieved this? It's the extended straight trim line. So although all the studies tell us that a scalloped only aligner brand is not very effective for correcting overbites and curves of spay, we can see here the moment you start using your straight extended trim lines, biomechanics changes, our outcomes change, and you actually get better results. Now hopefully if any of you come to the symposium in September, I'll have this case finished and then I can show you hopefully a nice result. Now we've talked about the research. Let's look at this deep bite case, which was a 63-year-old lady with excessive gingival display and a dental cant. Now she presented with a class 2 division 2 malocclusion. You can see an increased overbite and lower centerline discrepancy. And she's also got left maxillary and mandibular dental cancer. The canine relationship on the left is 3/4 class 2 and on the right quarter class 2. I know the angulation of these pictures means you can't see it properly, but I'll show you the therapeutic model in a second. Mild crowding with mild rotations. And this is her DPT. And you can see, look at the lower left, 7 and 8. They're mesially tipped. So that's actually a very difficult movement to do with clear aligners. Don't know if everyone agrees. Even with fixed braces can be a little bit difficult, so sometimes you need to use maybe TADs or something else, elastics to help you. Bear with me. There we go. So let's look at the scanned models to see the back teeth a little bit better. And actually on here you can see the severity of the tipping of those molars. Again, let's vote. What is the most difficult part of this malocclusion to correct with the aligners? Is it the overbite? Is it the center line? Is it the excessive gingival display, the gummy smile? The alignment, the tipped molars? So tipped molars at the moment is winning. The dental cant, gummy smile, overbite. So alignment and center line doesn't look like there's a problem with that. And I think everyone has voted. No, still voting. But it's interesting to see, a challenging case for one person might be different to another person. And how we approach our treatments is all very different. And like someone said earlier, if you gave a treatment plan to each and one of us in this room today, would you get the same plan? No, you wouldn't. You'd get a different plan from every person. We all get to the end goal, but we all approach it slightly differently. So most people said tipped molars and dental cant, a little bit with the overbite and gummy smile. So let's look at our aligner attachment design and tooth movements. Now, let me just see if this video works. Yep. So that should play. So you can see the correction that we're doing in the top middle there. So you can see in the red boxes, we're intruding the upper and lower labial segments, and attachments are necessary on the premolars. And for leveling curve of Spey, as I mentioned earlier, in deep bite cases, you need attachments on your premolars as anchorage. And the upper left 3, there's an attachment, and that's for root control. So we went with a vertical rectangular attachment to give correction of the angulation of the root there. And trim lines, what did I use? So again, I'm trying to correct a deep bite. So I wanted to use an extended trim line, but due to the severity and the displacements of the teeth, couldn't go in with a very extended from the get-go. So started off from 0.5 millimeter straight trim, and then slowly transitioned onto a 1 millimeter straight trim line. But again, this is what I received back. Now, this just proves we need to have the knowledge of our attachments, and I accepted that. I thought that was perfectly fine. But notice on our molar, if we're trying to correct that, and part of it was my fault, I should have specified to the lab that I'm planning on correcting that molar, because had I said that, they would have planned the attachments very differently. So communicating with your lab technician is very, very important. And certainly in my first year of using SureSmile, I found that there were a lot of communication issues on my part because I wasn't telling them what my treatment plan is. And yes, there is a clinical team there and Dr. Carroll's there to help if we need advice. But at the end of the day, we are the clinicians, it's our treatment plan, we need to tell them what we're planning to do. So this is her after the first set of aligners, and so let's talk about what's gone well and what hasn't. So the overbite and alignment is pretty good, but we still have a centerline discrepancy. The lower left molars are still tipped, but I didn't have an attachment on them.
Did you do the extraction of 38 and 48, no?
The dentist took out the wisdom tooth on the right side.
And
there was some sort of clinical issue with it. I think
and the 38?
The 38 on the other side. It's still there.
Still there?
Yeah, it's still there. I'll show you on the next one. Yeah, it's still there. The lower
and
right.
It's not easier to take it out before?
You could treat it very, very differently. There's many different ways you could approach this treatment. I'm going to show you how I treated it.
Yeah.
But yeah, you could take out, the wisdom tooth. You could do TADs to upright it. There's many different ways of treating that. But the lower right wisdom tooth was removed by the dentist, nothing to do with the orthodontic plan. Now, but notice we still have the cant. So, some bits are corrected, some bits aren't, so there's still room to work. Now, this is our refinement plan. Notice there's really only one attachment on there, and it's on the lower left 5. And that's because I needed to extrude that tooth, but also as an anchorage. And in this case, I decided not to take out the wisdom tooth. I wanted to try out, see how much I can push the aligners and the movements. So I decided to treat this with buttons and elastics. And I used 4.5 ounce elastics with a distal vector to the force to try and upright that. In terms of trim line, I also went 2 millimeters in the upper because I had no attachment, so there's nothing stopping you to go to the most ideal trim line. And the lower we went with 1 millimeter, reason being I had one attachment, so it would have made it more difficult to do 2 millimeters. So this is the patient at the end. So we can see centerline much better, overbite nicely corrected. In fact, there's a little bit of overcorrection. The right buccal segment is class 1, alignment is pretty good, and the molar uprighting has improved. Now, yes, you could, if you take out the lower left 8, then you will have the space to upright it much more effectively, but we decided not to do that. Yeah?
Did you use the class 2 elastics to correct the class 2 on the button and the inclined molar?
No. Didn't use class 2 elastics, but I did fail to mention something. So I used asymmetric elastics for the centerline correction. Now, if I go back, at one point in the last month of her treatment, we used right class 3 and left class 2 which of course will make the tipping a lot worse. But I waited until the tooth was fully uprighted before we started introducing that. So I was very aware and conscious, and that's why the class 2 elastic was only for a month. It was no more than that, and that was just to correct that center line. Now the other thing as well is if you're doing the class 2 elastics in a case like that, really your trim height needs to be quite high to get stiffness, to control that and prevent the tipping of the molar. Now she had one refinement, thank you. So one of the protocols that I use when I plan all of my cases, and I know with SureSmile we have less refinements, but every single one of my cases gets rescanned. And tomorrow I'm going to talk about why, because I have a very specific way that I treat both my fixed appliance cases and my aligner cases. And I use, it's a bit like building a house, so think of your first, bless you, set of aligners like building the house, doing the bricks, laying down the plastering. And my second set of aligners is the detailed painting and the decorating and your snagging. Because once you align the teeth, things look very different. And you may actually think, well, hold on, that tooth needs a bit of a tip. So I do a little bit of artistic contouring and shaping, which we're going to talk about tomorrow. Now, let's look at her smiling photos, and you can see the gingival display has improved. Now, one thing I will mention is she hasn't had lip fillers, but when she was smiling in the first photo, the lips are overstretched. In the second one, it's more of a natural smile. But we have still achieved some intrusion of those teeth. And if you look at the values on that chart, you'll see the level of intrusion. And even the upper left 6, we intruded by 1.1. And this is the panoramic x-ray. So yes, the lower right 8 was removed. The lower left 7 and 8 have uprighted. And this is just with a straight trim line and some elastics. Yeah.
Elastics, because
Thank you.
two buttons
Thank you. Sorry, say that again.
Sorry, I have a question about those vertical elastics.
Yeah.
You mentioned, you said you had the distal before, so you were using 7 and 7.
Yeah.
But you also have one button in the upper.
Yeah. So I put that button as a backup plan. Because, bless you, what I didn't want to do is start customizing the aligner. A lot of the times, midway, I might think, actually, that's not working. Let's add in these elastics. I'll do a hole puncher in the aligner customizer. But from the get-go, I introduced that because at one point, I was considering doing inverted triangular elastics to get intrusion. And then the second button was to get, sorry, not intrusion, extrusion. The second button was to get extrusion with a distal vector for the uprighting. But the button on the first molar is to do a V-shaped elastic.
Actually, were you using a V-shape or not?
At some point, yes. So it was a combination of V-shapes. So with her, every time she came in, I would have a look. I'll say, okay, today we're doing this elastic, next time reassess. But the majority of this correction is from the distal vector elastic. The V-shape was just to get a little bit of extrusion midway.
It was 4.5 ounces, and what was the length of it?
4/16, yeah. Or Gorilla elastics, depending on what brand you use. So, but yeah, going back to that, so you can see the effect of elastics with a straight trim line. The uprighting is not 100% perfect, but did I ever, when I started that case, think I could do that with clear aligners? No, absolutely not. I would have put a sectional fixed, make my life easy, and just correct that. But it just goes to show when you're using a straight trim line, things can be a little bit different. So what are the treatment strategies for correcting overbites based on the collation of the research that I talked about this morning? So these are my tips based on my personal experience and the research. So adaptive trim line design and extended trim line during leveling your curve of space is essential. If you're not using a straight trim line to correct your overbites, you're not going to get the same outcome. You will get much more effective overbite correction with a straight trim line. And the higher your trim line, the better the results. The way I work it in my head is I say, okay, I want to do a 2mm trim line, but why can't I? Is the patient, have they got difficulty in taking the aligner in and out? Have they got arthritis? How many attachments am I using? So all of these things you need to consider. Rotations, level of crowding. These are obstacles that stand in your way from using a very extended trim line. Always use attachments on premolars to prevent that lifting effect of the plastic when you're intruding your anterior segment. And I always like asking the laboratory to finish my cases with light contact on the anterior teeth or no contact, and heavy contact on posterior teeth. So when the setup comes back, I want to see red on my premolars and molars. And for me personally, that works very well. I always find that when I'm correcting my overbite cases with Sure Smile, I always get overcorrection, which I didn't when I was treating it with the Scallop brand. And there's no need for bite ramps. If you're using Sure Smile, you do not need bite ramps. Not necessary at all.
That's a question.
Yeah.
For the lower incisors, you have no protocol. In this one, for example, was the P protocol, that's protrusion, intrusion, and occlusion. With that system, it's not, or you have to see the X-ray, the bone,
Well,
led to make the.
Dr. Carroll will probably be able to answer that better, but with the Sure Smile lab, and we're going to talk about synergistic movements in a second, but the way the system works is that the laboratory and the AI will take into consideration the movement you're doing. So if your treatment plan, and again, this comes back to your treatment plan, because are you just intruding or are you proclining the teeth as well? If you're intruding and you're proclining, that's a synergistic movement, so it will work very well together. So you don't need any attachments on those lower incisors, you just need an extended trim line, premolar anchorage attachments, and that's it. So the system will stage the movements in such a way to get the best outcome from your movement. Does that answer your question?
Yeah.
Yeah, okay, good. Dr. Carroll, anything you would add onto that?
In these divide cases, the component is at class 2, right? So when you're moving the teeth, doing the class 2 correction, the tendency is that the lower teeth will flare, right? So when we do the setup, we have to check the crowding, how we're going to unravel the crowding, right? Because normally our protocol is not to move the whole segment out, right? We pick the one that is more backup and adjust the others to that one. And from there, we will have to retract all together and do IPR, because we have to compensate for the class 2 correction if it's either in block or distalize the upper segment. But you won't see these big movements of backal movement on the lower anteriors, because we compensate from the setup part. That makes sense? Answer your question? Yeah.
How do you communicate your fixed retention to the lab?
My fixed as an attachments or?
No?
The lingual retainer.
Yes.
Lingual retainer at the end of treatment, you
Yes.
mean? So with all of my cases, I always do fixed retainers and same day nighttime retainers. So I don't actually use the Sure Smile products for
Yes,
that.
but for the fixed retainers, you have in your preferences the communication for the lab.
I think she's asking Dr. Lina because whenever we receive the notes, like the doctor wants to leave a fixed retainer, they want to have a gap.
Ah,
between the
sorry.
chairs.
Okay, got it. No, so I have no. So I always, if you look there, it says light to no contact on anterior teeth. When I request that, automatically I always get overcorrection of the overbite. So my lower incisors always end up occluding with the very incisal third. So there is always space for my bond retainer. So I've never actually experienced any issues with that because I do that overcorrection. And that's the only strategy I do to create space for my bond retainer. And it's the same with my fixed appliance cases. With my fixed appliances, I will do finishing bends. I love finishing bends. I still haven't started using the robotically bent arch wires. I'm struggling to let go, but I will over-intrude those, and I will finish with a little bit of an incomplete overbite.
Another tip also is like, because the way that our SureSmile system measures the overbite, it measures from the lingual of the lower anterior to the, to the backal of the lower anterior to the lingual of the upper. That's how the system measures the overbite. or the overdentum, sorry. So you can tell the technician, for instance, give me 1 millimeter. We have a grid, and they will put the grid, and they will measure the buccal surface of the lower with the lingual surface of the upper. And they will measure, because every square of the grid is 1 millimeter. So today you can ask your, in the 101s to show you the grid, and if you need clearance for instance, the lingual retainer, or you need clearance to do reconstruction or to do crowns, we can measure with the grid from the buccal, from the lingual to the buccal, and you will get what you want. But they just need to know how you're measuring the overjet, because some doctors measure from the buccal to the buccal, and we measure from the lingual to the buccal of the lowers.
So we've talked about trim line attachments. Let's briefly talk about tooth movements. So many aligner companies look at tooth movement based on standalone or isolated movements. But tooth movement is much more complex than that. So Schwarzschild takes into consideration synergistic and antagonistic movements. So it will combine the movements that work well together to give you better outcome of that movement, and it will separate antagonistic movements that don't work well together. And Dr. Carroll showed you that table with what's synergistic movements, what's antagonistic. I've converted that into visual diagrams, which I'll show you. Now, let's talk about a powerful feature of Schwarzschild software called variable movement constraints. So there is an optimal amount or degree of movement per aligner. And think of it like a speed limit. And this speed limit is there to ensure, safety and predictability when we're carrying out our tooth movements. And many of the competitor brands don't take into consideration that some movements are antagonistic and others are synergistic. So, but with Schwarzschild, what they will do is they will slow down your antagonistic combinations and they will speed up your synergistic. Let's look at this example. So here we've got buccal movement and palatal crown torque. So this is an antagonistic movement. And if you tackle the two movements simultaneously, you need to slow down the movement. You can't go at 0.2 millimeters per aligner, it needs to be 0.1. But if you separate the movements, it's gonna be much more predictable. Now, there's another variable movement constraint, which is an accommodation stage. And think of it like allowing the patient to adjust. So your first aligner allows the patient to get used to having plastic in their mouth, but it also has a reduced rate of movement in the first aligner to make it more comfortable. Now, another feature is root balancing. So this helps minimize excessive root movement during your synergistic combinations. So let me explain what that means. So if you look at this diagram here, you'll see that the usual journey that our tooth takes to express buccal movement and buccal crown torque, those two movements are synergistic. But in the old version of the software, the two movements did not occur equally. So you can see there, in your first aligner, you're getting 50% of the torque happening first, then 25% of your buccal movement, then 100% torque, then 50% buccal. So you can see what's happening. There's a stop-start movement of the teeth until the very end, until 100% of the torque and buccal movement has been achieved. But in the new software, you'll notice that the buccal crown torque and the buccal movement is much more synchronized, almost like a dance. So 25% of your torque with 25% of the buccal, equally happening in each aligner until you get what you've achieved. And this is much more consistent with the natural biomechanics of tooth movement. So let's take a look at buccal movement and buccal crown torque. This is synergistic. What about buccal movement with palatal crown torque? You can see the forces are going in sort of opposite directions, so that's antagonistic. And this is the synergistic diagram from the white paper that Dr. Carroll and Dr. Hard have been working on. But you can see synergistic movements, there's generally more crown-based movement and less root movement, so they're much more easy to carry out. With antagonistic, the movement is more root-based, so it's going to be much more difficult. Now, lingual movement and lingual crown talk, what does that look like? Again, you can see everything is kind of going in the same direction, so it's synergistic. Lingual movement with buccal crown talk, that doesn't work well together, that's antagonistic. And again, this is just a video illustration of what Dr. Carroll showed you earlier, that table with antagonistic synergistic movements, but this is what it looks like in real life. I hate tables, so I like to visually see how teeth move. Fine, nearly done. So, now if anyone wants these, let me know. Now, rotation with intrusion. So if you can combine your rotation with intrusion, you're going to get much more success out of that derotation. Whereas if you're rotating with an extrusion, that's not going to work so well. So you need to really separate those movements. And the laboratory know this, and they will help with that. Distal tipping, distal movement, again, same direction, works well. But if you're doing distal tipping with mesial movement, that doesn't work well. You can see the forces are running in the opposite direction. Mesial tipping, mesial movement, same thing, synergistic, and mesial tipping with distal movement, antagonistic. So why is everything we've talked about so important today, and the ability to customize your aligners to your patient's needs? Well, not every case is the same. So to finish off with, let's talk about this case. Now, I wouldn't say this case is particularly complex, but it combines everything we've talked about. So Class 2 Division 1 on a skeletal 1 base with mild crowding, increased overbite, centerline discrepancy. You can see a little bit of tooth wear that happened from a bicycle accident. Overjet of 5 millimeters and an upper centerline, which is to the left by 2 millimeters. So you can see asymmetric dental arches. Excuse me, my voice is not lasting any longer. With mild crowding, molar relationship and canine relationship on the right, 3/4 Class 2, left Class 1. So let's quickly vote. This is the last mentee. What's the most difficult part of this malocclusion to correct? So is it the overbite, the midlines, right buccal segment, the crowding, or the overjet? So right buccal segment is the number 1 in the lead at the moment. Now, with the essence of time, I'm going to take the blue one as the number 1 vote. We've only got 2 minutes left of this. So, yeah, right buccal segment is what most people agree with. So how did we get here in 15 months? Well, I used a 1 millimeter straight trim line and Class 2 elastics. Very, very important to get your talking, more complex bodily movements to have that straight trim line. Again, we've got some attachments there for anchorage, but also correct angulation, some extrusions. And let's talk about the attachments a little bit. So you can see extrusion of the premolars in the previous one. And we've got quite a few attachments there to help us with those movements. But notice that when I talked earlier to you about when you're distalizing that you generally need to use attachments, notice with a straight trim line we haven't really got any attachments on our molars, but it still worked very, very well, again, because your forces and biomechanics are different when it comes to a straight trim line. I chose 1 millimeter because he had quite a few attachments. I didn't think we could go any higher with that. So, quick case overview. 15 months, 1 refinement, and the refinement was to get asymmetric elastics in, correct the midline. And again, I did a bit of Soflex contouring to smoothen the lower chipped edges. And the dentist, my husband, did a little bit of composite edge bonding to repair the chipped edges. And significant improvement in the buccal segment, the overbite, the midline. The upper right 3 angulation could be a little bit better, so maybe we could have done a second refinement with a vertical attachment to help correct the angle, but the patient wasn't really bothered about that. So, yes?
So which midline was shifted? Upper or lower?
The upper was off to the left.
Okay, so you correct midline only at the refinement using asymmetric elastics, or you do it also asymmetric IPR, or?
It depends. So when I'm doing my prescription for the laboratory, you can select how you're going to correct those things. So whether it's asymmetric IPR or whether you're doing elastics, I do both. So I give them the permission to do asymmetric IPR, but I always introduce elastics. If I'm doing a centerline correction, in my hands, I find it very difficult to correct it with IPR alone. So I will introduce asymmetric elastics, not necessarily from the get-go. Depends on the severity of the case. If, for example, in this case, I introduced in refinement, so it wasn't from the start. Sometimes I will modify the plastic myself with hole punches, add the elastics myself. But the problem with that is if you're then simultaneously doing other movements, the moment you cut to your plastic, you're losing the automation, so you've got to be a bit careful.
Which elastics do you use?
So I tend to use, so with the elastic, for you to get the force that's stated on the pack, so 4.5 ounces, you need to stretch it triple its length. So I check in the patient's mouth. Most of the time I use 4.5 ounce elastics, 3/16 of an inch. But if, for example, I'm stretching the elastic more than 3 times, then I will move to something that's slightly bigger diameter.
I wanted to add, Dr. Mina, that you have to think the plastic as you think with the wire, right? If you're gonna do class 2 correction, the wire, like the sugar small wire, has the information to move the teeth, for instance, extrusion. But the elastics enhance the power of the wire. It's the same with the plastic, right? We can plan the dental movement to go there with asymmetric IPR, with segmental distalization, but the button and the elastic help the plastic to move the teeth. So like when you have a cant, for instance, when you have a severe cant, we will suggest that you may need sometimes to add vertical elastics to help the side of the cant, but you need to have an anchorage on the other side. So you have to put elastics on the other side because otherwise the patient the cant is gonna shift to the other side, right? So, in the wire business, the brackets comes with the hooks, and it's easy to put the elastics very fast. In the liners, you will have to think your strategies and tell us, I want the button here, or I want to sleeves for anchorage, and the button here for correction. And we can do that, because otherwise, the teeth won't keep up with the movement of the plastic. They need help to get the movement done. And I was going to say something else you said, but I forgot what it was. But I remember.
But to add on to what Dr. Carroll said, whether I use elastics or my methodology for thinking and planning elastics is no different to fixed appliances. So if in that case in fixed appliances I would have introduced elastics, I'll put it in with the aligner. So my treatment planning is not really different when it comes to aligners and fixed appliances, but the methods and strategies in terms of like overbite, I know, okay, the protocol is attachments here, light contacts on the anterior teeth, overcorrect the posterior teeth. So there are certain treatment strategies that are different, but when it comes to elastics, the way I treat it is the same way that I would with fixed appliances. So multiple key features to streamline aligner workflow, creating predictable treatment plans. We talked about the aligner design customization, why that's so important, and hopefully those of you who are using the Ortho platform, you're already using an adaptive trim line. Those on the aligner platform, you can request the laboratory to do that for you. Now, having better forces, better biomechanics means more predictability. That means fewer refinements and better outcomes for our patients. Now, I'm genuinely really excited about the future of aligner orthodontics because since 2021, there's been a lot of research that has been developed just looking at how straight trim lines really changes the way we move teeth. And at the moment, the same group that I talked about earlier and some other groups, they're working on a lot of this research, and I'd love to see nicely designed clinical trials looking at how our straight trim lines interact with our attachments, because we don't have that at the moment. So this is all new and we're all learning. So I think things are rapidly going to change how we're managing our aligner cases. And I know there are some companies that only use a scalloped aligner system, but I think that's going to change in the future as well once they see, especially the systematic reviews that tell us straight trim lines are the future. So thank you very much, and thank you for bearing with me with my voice. I managed to last. And tomorrow we're going to, as I said, talk about IPR and how to manage aesthetically challenging cases with IPR, which is my passion topic. I know it doesn't sound exciting, but hopefully I will make it exciting for you. And then we're going to talk about the strategies when treating extraction cases with aligners. And then we'll finish off with a little hybrid look at how to treat an impacted canine case, just for fun, and open some ideas for discussion. So thank you very much.